So I've got the task of talking to you about, this concept of damage control pre-hospital care, which makes sense and doesn't make sense at the same time, and I'll explain to you what we think we mean by that in a minute. But I'm going to talk a little bit more broadly about the tools that we have in our armamentarium in general to treat hemorrhage, and when to use those tools and when to put them away, keep them in the box, when to pull the trigger and when not, depending on the situation. You'll see what I mean as I come onto it. And I'm sure it's stuff that you've all faced with before. In fact, you know what we didn't do at the very start? I think I'm sort of used to this kind of audience, but it would help me to know how many of you work in pre-hospital care at the or ever have done. Can you just put your hands up if you work in pre-hospital care? Thanks. And put your hands up if you haven't worked in pre-hospital care. Okay, so the vast majority work in pre-hospital care. And of those of you that don't work in pre-hospital care, you work in major trauma centres, or that's going to be hard to do your hands for that one, but I'm presuming you are involved in other ways in the care of these kind of patients. So I think these are patients that you'll recognise, and I'll try and whiz through some stuff as quick as I can to make the point. But we are evolving in the way we're thinking about this, partly because of, well, entirely really because of what these guys have just told us about the mortality rates out of hospital and the brick wall that we face in trying to actually make a difference and put a dent in these figures and make tangible outcomes different. And we've all got our own personal scars and stories, and any of you that have been doing this job for long enough, if you know at all, will have had to talk a parent through their son's death, or their brother, or their father, or their mother, and that's horrible to have to do and to explain to people. And the fewer times I can do that, the better. So that's my own personal incentive, and I think probably the same for most of us is our incentive to make a change. So we do want to make a change. We are continually updating our guidelines, but we've made a bit of a bigger change over the last year or two, largely in terminology and in the way we're describing what we're describing. And by that, I mean kind of this point at the bottom, more trying to talk about the condition of exsanguination or hemorrhage or catastrophic, shock, as opposed to interventions. And what we've noticed, I've certainly noticed it as someone that does a lot of the training, if you teach people and train people to do an intervention, bizarrely, we start to think of patients as almost, not as interventions, but we start to think of them as, oh, that's a patient that needs a thoracotomy, that's a patient that needs a balloon, that's a patient that needs a blood transfusion. They might be, but they're patients. They're just patients that have been driven over by lorries or stabbed or shot. They don't care what intervention we use. And as I said before, I don't care what intervention we use. We need to think about the condition that they are suffering. We need to learn more. And I know Robbie's joking when he says that I wasn't convinced, because I was with him on the trials where we watched it happen, didn't we? In animal models, we watched the coronary perfusion drop when you put a hole in an arterial vascular tree. And it's quite striking to relearn everything that you think about shock and hemorrhage, and then think, how do we describe that to our colleagues and to each other? And this is often the model that is thought about certainly by me, when I think about exsanguination, I think about torrential hemorrhage, and we're losing blood from the system, and that's the problem. And yes, it is the problem, but we should challenge that concept and make sure that that's accurate. And if it's not accurate, why is it not accurate? And you've just heard from Robbie about problems with the vasculature, and it's not just about losing volume, right? It's very, very, very much about keeping this happy and healthy and keeping this happy and healthy by way of maintaining the structure in the normal, plumbing and the anatomy, which perfuses and maintains diastolic pressure, perfusing the heart, and maintains blood pressure, perfusing the brain, to give you a live, healthy, happy patient at the end of it. What's our means to change these kind of things? Well, we're quite lucky. We're surrounded by people that are interested in learning and discussing and putting in time to do data, to do research and gather data. And we've got a very, very tight governance system. I think so. It can feel a bit like you're under the spotlight a lot of the time, but that's what we sign up for. And it's nice to feel that others are looking at what we do closely. And again, I personally think, I mean, this is a bit of a plug for a sort of bit of a hobby horse of mine, but I think the way that we train is important, and I can talk to some of you guys about it afterwards if you like, but I'm working with a group of people on simulators and just how we simulate this kind of condition. Because, for example, if I give people a REBOA simulator, they come into a training session knowing that they're going to put a balloon into this patient. Yeah, it teaches them how to do the balloon, but it doesn't teach them how to treat a patient that's bleeding to death. The idea of this, I mean, it's a prototype thing we've got going on, is we need to teach people on a simulator that can bleed and be resuscitated, that can have a thoracotomy, that can have a balloon, that can have a subclavian line, that can be picked up, chucked in an ambulance and gone to hospital. You know, that's the point. It's not about the intervention, it's about the condition and the various different ways to skin that cat. That was that weird cat diagram that you saw earlier, in case you were wondering. And speaking of cats, you know, for me, it's about being surrounded. But it's a bit cheesy, this side. I'm sorry, it is quite cheesy, but being surrounded by people who constantly want to change and who are brave enough to try new things and brave enough to suggest new things helps a lot. And it, you know, really has got to the point for me where either we just succumb to the misery of telling parent after parent after parent that their child is dead after being stabbed, for example, or we do something about it. And I'd much rather do something about it. So what is the problem? What is the problem that I'm waffling on about? The problems are multiple. You've heard about a lot of them already, but I've got a little list here in front of me, and I'm going to read all of them out. You know, you've just heard a lot from Robbie and Zane about data and physiology, and are we doing okay? Yeah, we're doing okay. We are. I think we're making a difference, but it feels like a small difference, and it feels like it could and should be bigger. And that's why we've got our sights set on more for the future. Are we still learning? Very, very much so. You know, I'm totally on board with what Robbie and I are always talking about physiologically, and I just want to learn more about it. What are our biggest challenges? Well, it's really hard to diagnose people accurately in the pre-hospital phase, as you'll all know. Sometimes you think they're bleeding and it was their brain. Sometimes you think there wasn't a pneumothorax and actually there was a massive tension pneumothorax. It's hard. It's difficult to diagnose people accurately and therefore to act correctly and quickly. It's difficult. And so rationing our interventions, if we're talking about time, which is very much what I'm going to be talking about here, is rationing our interventions. How do you do that if you don't know exactly what is wrong with your patient? You have to take a bit of a punt and you have to gather as much information as you can and you have to accept that you might be wrong some of the time. So we're working out how to do that with as little risk as possible. The fact that there are any deaths in the pre-hospital phase is troubling, but the fact that there are so many is extremely troubling, and that gives us something to work on. Breaking, you know, dogma and tradition is something that we're quite used to doing, and we want to continue doing that. And the system's response is very important. I think you're all from, I won't go through the room, but you're all from very different places in different systems. And I think you'll maybe relate to this, that if the system is not ready and the system isn't bought into whether it's a big intervention or a change in mindset, even what I'm about to talk about, which is the term Damage Control Prehospital Care, the system needs to be bought into that and understand what you're talking about when you phone up and say, this is a DCPC patient, we'll be with you in 10 minutes. I mean, that now means to many of us, oh my God, okay, this is going to be pretty tasty and a lot might not have been done and there's going to be more for us to do than we're used to because the patient was going to die without it. So bringing the system along with you is extremely important. We need to be agile in how we learn and how we develop and evolve as trauma systems. This bothers me. It's another graph that shows how early people die and how many people die pre-hospitally from hemorrhage. This bothers me. Someone I treated close to 15 years ago, and I feel like we are a long way on actually from the time which I treated Mary. This was before we carried blood, before we had a balloon to use. This was before we did use thoracotomy in the same way that we do now. But still there's a lot of people dying on the streets of London and elsewhere, I'm sure. And if there's anyone who's not going to be stuck in a rut and caught up by that, it's people like this. And I show this with the utmost respect, Robbie, because this is Robbie with a few splatters of blood on him. I'm not sure you can see them from further back, but he's covered head to toe in little speckles of blood after handing a patient over that he intervened on earlier than most people would. This was a guy that had a tamponade, actually, and was confirmed on ultrasound, and the team predicted he was going to arrest. They knew he was suspected he was going to arrest. A really big tamponade. They're loading him. It's quite away from hospital, and they jumped in very bravely, very early, in exactly the right way, with a slug of ketamine IM, just as he was starting to brady down, before he'd arrested, because we've seen far too many arrest and not come back. And I know I'm straying into tamponade now, but what I'm talking about is the mindset of intervening early and doing something different and pushing the boundaries of what we normally do to get more survivors. And that's what Robbie did that day. And I think if I use Robbie as an example, forgive me, Robbie, but it's all praise. It's all right. Robbie thinks very hard about his scene times. Okay, we can talk all day about the challenges to being quicker, being better, saving more lives. But these are some of them, and they're hard to completely negate. But I can tell you, this man and all the people I work alongside think very hard about their scene times. They think very, very carefully about their diagnoses, and they use everything in their power to diagnose accurately. We play, well, maybe it's just me, I play a game called the CT scanner game. The name is the clue. Try and predict as accurately as you can what is wrong with the patient. Not just the chest is smashed up, they've got a head injury, they're bleeding from their pelvis. What exactly, what blood vessel, how much? That's what we want to know, to be able to know what to do. We're all bothered by pre-hospital deaths. We all want the system to be bought into what we think, and if they're not, we want to know why, and we want to learn from the system. And we hear this a lot in our D&D sessions when we review cases and go, learn from every case that we can. I've noticed hearing this, I don't know, either I'm noticing it more or we're hearing it more. And that is, we went a bit off SOP, or we strayed a little bit off what the guidance says to do this, this, and this. And almost invariably, this, and this was exactly what the patient needed. We recruit very senior people, as most HEMS teams do, and these people are signed off and trained, and they know what to do in the heat of the moment. But the fact that they're saying we went off SOP, to me, means that the SOP is wrong. And we need to change the way we're guiding and teaching these people so they don't feel like they've done something naughty. They've actually done something quite groundbreaking to save someone's life. A case in point. So I'm sure probably everybody will relate to this. Will have either heard of a case, had a case. I've certainly had this happen to me and had to console colleagues as well after it's happened. Imagine a patient who you get to, for whatever reason, blunt or penetrating trauma, is extremely shocked. You take one look at them and you think, oh my God, they're going to die. And I'm absolutely scared witless of what's going to happen and how I'm going to do everything I need to do quick enough and well enough to get them to survive. And you try for access, peripheral, central, doesn't work, it goes wrong, it takes too long. You then decide maybe I need arterial access because actually this is torso hemorrhage and I think a balloon aortic occlusion might help, and that goes wrong, takes too long, it's fiddly. You then find the patient continuing to deteriorate. I mean, this can happen over minutes, if we get to patients early. I know everybody's system's different, but patients can change so quickly, can't they? Before you know it, they arrest, or they're peri-arrest, and you end up opening their chest. And then the last tragic stage in the game is that you are pronouncing life extinct, writing down a time, and a badge number of a police officer because you couldn't save them. And this has happened, and it still happens in our system recently. So, you know, when I was asking you what you thought about our service and your own services, I don't know about your own, but it certainly still happens in ours, and we still, to this day, we're not by any means perfect. And we do still hear about cases where the team have essentially tried and tried and tried on scene, and someone has died. Right? So you can't ignore the fact that they were not moving to hospital while this desperate attempt to save them was happening. And I'm not saying it was wrong, because I've done it myself, but we're in a bit of a pickle. So what do we do? Well, we've got this box of tricks. We've got an ever-increasing box of tricks to use. And the question we always ask ourselves in these situations are, well, what do I choose? What do I use? What do I do? What's my plan B if that fails? And there's this term, you know, that has been knocking around for years, decades, I don't know how long, but do we stay and play or do we scoop and run? I don't like those terms. Again, I was going to ask you to put your hands up, but there's probably no point. Does anyone want to put their hand up if they don't like those terms? Why are you bored of putting your hands up? Fondue's coming soon, I think, don't worry. I don't like them because I think it's like it's old hat. It feels like it's something that's keeping us stuck in the past. Surely we should be scooping and playing or running and playing. Call it whatever you want, but we should be moving towards definitive care. Someone like Zane, I want to be with someone like Zane before I end up in a chest that I don't want to be in, right? And I can do so much. There's all these different things. I won't go through every single one of them, but essentially they boil down to this. Can we fix them? Or should we just go to hospital? You know, and neither of those two on its own works, does it? The reality is often very different. There's extrication and there's movement and there's transport and there's all sorts of things that get in your way that, you know, you can watch the patient deteriorating as you're trying to save them, and push comes to shove and you end up having to do something quite extreme. So how do you choose what you're going to do? So I'm going to lob a bunch of cases at you. Not too many, hopefully. And talk not just about damage control pre-hospital care. I'll explain that, I promise, in a minute. But just generally about what we can do for exsanguination. And the first three cases, they're all real. These are all real cases that we've had and gone through. And some of them I've treated myself and some of them have been others. But the first three are all a young person stabbed in the abdomen and groin, right? But with different physiological states for whatever reason. And I want to ask you, because I know it's getting late and I know everyone's hungry, but I do want you to at least pretend to interact with me a little bit. So I want to ask you what you think. This person, can you see that picture? Is it? I'm mindful at the back it might be a bit small, but if you look over here, there's a poor person in the middle of this mayhem who is extremely sick. And yes, I know you can't see the soles of his feet because his shoes are on, but you can tell, even just by the way he's lying, he's extremely, extremely sick. There's loads of people around him. It's quite early in the phase of his care. There's quite a bit of blood on the floor. Sorry, kids, it's a bit gory. My kids are in the audience. But they've seen it all before. Look at the obs. I want you to look at the obs, right? Then the exact numbers don't matter so much. But this patient is tachycardic. This patient has a low blood pressure, but a blood pressure. The non-invasive, let's say for now, I don't know, I want you to ignore the invasive. You can look at both of them if you want, but non-invasive 100 systolic, invasive says, 59 over 44. That's another thing we've learned. They're often wildly different, but they're tachycardic, they have a blood pressure, they have a SATS trace, they have a reasonable end-tidal 2. Let's assume that's nasal and an oxygen mask. What's the thing to do for this patient, right? They're stabbed in the groin, stabbed in the belly. What's the right thing to do? And how extreme does what we do need to be? Who wants to just answer that? Bearing in mind, the longer it takes for people to answer, the longer we're going to be standing here talking. Someone shout something at me. What do you want to do for this person? Stop external bleeding. Yeah. Go for it. You can try, but it might be too quick for you, John.
Just we'll for the recording, that was stop external bleeding.
Stop external bleeding, definitely, yeah. Right, we miss the obvious stuff, don't we? There's blood all over the floor. All right, any advances?
Access and fluid and blood.
Access, yeah.
And blood.
The basics, right? Access and blood. Okay, brilliant. How much blood?
All of it.
Yeah, it's hard to know, isn't it? It's a silly question, but he looks. If someone who looks like that, I'm sort of less bothered about his numbers. I just want to get loads and loads and loads of blood into him, because it's he's going to die. All right. Someone said REBOA, I think, somewhere in the audience. Hold that thought. Hands up who thinks he needs a balloon in his aorta. Bearing in mind, it is a bit of a silly question because it's hard to know from just one. You're not wrong. I don't know why everyone else is so scared of putting their hands up, but I'll bet you one or two people think. I mean, I think he might. I'm looking at him thinking, oh my God, if he doesn't need it, who does? But let's just hold our horses for just a minute, right? And maybe compare him to another patient. Because I'm not saying he doesn't need a balloon, but I'm saying I would be thinking, let's just maybe, if there's external blood loss, control that, get a line in, pummel him full of blood. I'm not going to give him any more than a few minutes to declare himself while we do those things. And for example, a nice, neat solution we've discovered is putting a full French arterial line, small arterial line, in the groin. And if he turns out to get better and better and better, great. Put the balloon away, we're okay.
I thought his blood pressure was 100 over 50, but I don't know when that was taken.
Yeah.
And now I have an accurate blood pressure that is 60 over
Absolutely.
50, so I think
Yeah.
it's plummeting.
Yeah, I'm not saying you're wrong at all. And I think what I would probably do, most of us now would either just put a balloon in, but I like to think most of us now in the early phase, because we're learning in the early phases things can change quickly, put in an art line, a full French, less harmful because it's smaller, measure his pressure, see his response. If it responds really well, he'll get away without it. If it doesn't, we've already done the hardest step. He can have a balloon on the way to hospital quite easily. Compare him to this one. Now, I showed you this screen as well a couple of years ago. I'm going to have to be quick, actually, so I don't get more glares from Singer. What's the difference here? Not same person, but stabbed in the abdomen, the groin. What do you notice that's different about that monitoring? Reflecting on what Robbie was talking to us about.
Bradycardia.
Yeah? Why does that bother you?
Bradycardia might be a sign of cardiac ischemia.
Yeah.
So he's further down the road already.
Yeah, and it can be all sorts of things, can't it? They can be vagal, they can have all sorts of reasons. They could just be brady and then speed up again, but often it's pre-terminal. And actually, in this case, I can't believe I took this picture because the patient was dying, but I found it so fascinating physiologically, I took a quick picture, but because he kept responding to blood and then would go, oh, I'm going to die, and start vomiting, rolling his eyes back, pulling the mask off as he bradied down. He was having a massive MI. And I think he was having it because his diastolic, it dropped lower than this, much lower. And the lower it dropped, the slower he went and the more dead he looked. Right? So don't worry, I didn't let him suffer like that for too long. But it was interesting to see. He's in a more extreme state. He is someone, to me, who, if he doesn't immediately pick up, he needs aortic occlusion, I would argue. Should we flick through to the next one? Oh, hang on, what did I just miss there? Well, what about the UK REBOA trial? Am I not bothered about that? Am I just ignoring international randomised control or national randomised control trials that my name is on? My name is on that paper. Am I completely ignoring it? Huh? Yeah. Did you hear that? This patient wasn't in it. A completely different patient. This patient is like 20 minutes after his injury, not 2 hours after his injury. It's completely different. That's why I want everyone to understand. I love the UK REBOA trial. I think there's a lot of good that has come out of it, but it's not relevant to this person at all. Well, it is in saying don't waste loads of time sticking a balloon in. If it doesn't work, think of something else. So what if it doesn't work? What am I going to do? I've just said to you, I'm convinced he needs his aorta occluded. So what am I going to do? Hope that maybe someone said crack his chest. Yeah, I mean, I think it's a ballsy move, isn't it? And it feels less finessed and it's more dangerous. But look, if he continues on this trajectory and gets worse, I have to compress his aorta. That's one of my options. Let's put it that way. Does this matter? I'm only going to Oh, God, hang on, I'm going the wrong way. This is probably good. The slideshow is telling me to hurry up. I'm only going to say, look, whether I'm more worried about this one, because if the blood has gone in and not out, I just feel a bit less able to control this problem. So I'm even more worried. Again, sorry about the gore. This one, what about that? Patient looks like they've gone into cardiac arrest. What am I going to do? Well, if I'm going to do something, it has to be bloody extreme. Excuse my language. It has to be very extreme. My only question on that then, if anyone wants to say to me, open his chest, how are you going to open his chest? Clamshell or left lateral for this person? Yeah, whatever you're familiar with, someone said. Love that. Yeah. Why are you opening his chest? Yes. Whoever said compress the aorta. But my point is, if the rhythm is either absent or very unhealthy, I'd just do a clamshell because you need to compress his heart properly, and even my small hands, I can't get in there and do both. I want to get through to... I was going to describe these very briefly, only to say there are two cases we've got. I'm not going to put all the details up because it doesn't matter, but two cases fell from very similar heights, one of which Robbie treated quite recently, one of which another Rob actually treated quite a while ago. One of which had a very clear vertical shear fracture, a well-maintained cognition, a normal head, relatively normal chest, and was dying rapidly and needed a balloon, had a balloon, responded well to a balloon. The other one of which, Robbie decided not to put a balloon in. I actually saw it and said to him, hey, how come you didn't stick a balloon in that guy? And he said, well, because he didn't look like he was bleeding to death. And he was unconscious, and he needed a jaw thrust, and he had ventilatory issues. So he needed, I'm coming to a point here, he needed more. He needed the full HEMS package, like as in he needed intubation and ventilation, because he would have died of ventilatory failure. He would have died of airway problems, quite possibly, as well as his hemorrhage, which it turned out not to be as quick. And thank goodness it had someone like Robbie's eyes looking carefully to understand, is this a rapid arterial bleed or is it a slower venous bleed? Maybe it's hard to guess, but he got it right. And look, he did really well. No, this was the one that had REBOA, sorry, not Robbie's one. He's not quite ready for pictures yet, Robbie, but he is doing very well. Now, DCPC I'm going to rush through very quickly. And that's kind of the point of DCPC. It's meant to be very quick, so that's fine. You might be sitting here thinking, well, that's nothing new. Damage Control Prehospital Care. Yeah, we all know about damage control care in trauma. What are you going on about? The point is doing the minimum necessary. And I think if you reflect on that case that we said was horrible, where we got stuck with someone trying to do all these interventions and they died with us on scene when they might have been able to make it to theatre in that time, you've got to question what you're doing. And I have to question it, and I'm like one of the leads for training REBOA and all these fiddly interventions. And we have to change tact. And I think the simplest way to describe damage control pre-hospital care is this saying that many of you might have seen. It's an old prayer. My mum used to have it, carry it around everywhere she went because we were driving her mad. But it says, God, grant me the serenity to accept the things I cannot change, the wisdom, the courage, what is it? The courage to change the things I can, and the wisdom to know the difference. It's a thing called the Serenity Prayer. The point is, it's about recognizing, can I control this problem in front of me or can I not? And if I can't, I need to be wise enough and grown up enough to say, I can't control this, I need to go. And I might need to be ballsy and do stuff en route. This is a case I'm going to finish on and then hand over to Ben. So this case was a young lad, again, tragically, shot with a shotgun really close up in the back of the chest, a couple of times by the looks of it. There was a massive crowd. When a colleague of ours, Dan, arrived with him, he was peri-arrest. He looked awful. The description sounds like someone who is literally about to die at your feet. There was a crowd around him, so I think push came to shove and he actually had to get out there anyway, physically, but also he felt clearly this was chest pathology, and he felt there was no pathology in the abdomen or anywhere else for that matter. In fact, his description was he could fit his fist into the chest of this boy and feel to the point where he went, oh, hang on, I shouldn't really go any further than that. Something bad is happening here. So you're faced with this person who is dying and has this massive hole in the back of their chest. What are you going to do? Someone put their hand up, quick. Quick. Someone, please. Do you want to do anything to him on scene? What's in there? What's in his chest?
Yeah, maybe I'll just try to put my hand into the chest and compress the aorta and then make a run for it.
Well,
There's a hole already.
Depends where the hole is. I think that hole was more on the right than the left. But I think the feeling was it was just mush and we couldn't tell what was going on and he didn't want to push any further. The point I think I'm making is that we don't know what the hell is in there. And I can pretty much guarantee you, if I go in there and try and control it with a thoracotomy, I'm not going to have as much luck as Zane or any of his surgical colleagues. I really, really, really want to be in hospital with this kid. So what the team did is what I now hope I would do, and this is what we're describing as damage control pre-hospital care, and which led this lovely young boy to be able to come up, stand here with his mum on Dan's birthday and take a picture. They put in a line. In fact, he just put the wire of a subclavian. I know that's very controversial. I shouldn't say that, but that's what he did, and carried it on en route, held onto it and carried it on in the ambulance, or as the ambulance was leaving, filled him with blood and just ran to hospital. He decompressed his chest on the way, didn't put chest drains in, 2 holes, let the tensions out. There was tensions both sides, chest seals on. We ain't got time for chest drains. There's too much going on. Filled him with loads and loads of blood, ultrasounded him to know that there was no tamponade, that he was fast negative in his abdomen, and it turned out, it's bloody lucky he did all that because he had a hilar injury and he needed a thoracotomy by someone who knew what they were doing. And I've done a lot of thoracotomies, and I would say I'm not someone who wants to deal with that. So that's what we're describing by damage control pre-hospital care. Now, I will just flick through to say that when they're stabbed all over, and that's what I was faced with last week, and when the pathology is not so straightforward, it can be a bit perplexing. And you just have to be really careful. You have to do all the stuff we've talked about. Be careful, look at the physiology, look at the trends, look at the anatomy, work out what you think is going on, and is it right to run to hospital with this patient? Do we do it in blunt trauma? We've pretty much decided, I mean, this is really very recent, in the last few months we've written some stuff down about this. We've decided we're quite likely to get it wrong, and we actually think we might have got it a bit wrong a couple of times. Not wrong, but it's easy to miss a pneumothorax, much easier to miss a pneumothorax in blunt trauma. It's easier to get the diagnosis wrong in multi-poly blunt trauma. And I think only if it's very, very clear, like, for example, this lady I treated years ago who had a clear lorry only over pelvis. Now, she got a balloon, but if I couldn't get a balloon in, you could argue, if she needs a chest opened, opened it. If she doesn't, just run to hospital, because there's nothing else here I need to treat. Her airway doesn't need managing, her breathing doesn't need managing. The only problem is exsanguination. And I don't want to end up in her chest. Now, she was glad that I didn't, I think. I'm just looking for the end of where I can stop this and move over to let Singer talk. And it's just to say that the point is still the same. We haven't changed anything that we're teaching you. We're just saying that there's a different tact if you look at the patient as someone with a failing heart and a failing brain, and you can't control the problem. You have to run, and you have to do stuff en route. And we've all learned, actually, we thought it'd be really hard, but you can put art lines in en route, you can put subclavians in en route, you can do a hell of a lot of stuff en route. Chest seals are not that bad. Little slug of ketamine if needs be to tolerate them. You can do a lot of stuff en route to hospital.